Welcome everyone. In this video we shall be talking about congenital hypothyroidism and discuss all the MCQs related to it. So moving on to the first question. Congenital hypothyroidism is defined as, now congenital hypothyroidism is defined as decrease in thyroid hormone since birth. Right, hypothyroidism developing after 3 months? No. If it develops after 3 months it will be considered as acquired. Deficiency of thyroid hormones present at birth? Yes, this is our answer. Transient hypothyroidism due to iodine excess is actually known as transient neonatal hypothyroidism. Transient neonatal hypothyroidism. And any thyroid hormone deficiency irrespective of onset, this is also false. It is not irrespective of onset, it has to be since birth. Okay. So moving on to the next question. Which of the following are causes of transient congenital hypothyroidism? Now, transient congenital hypothyroidism causes maternal antithyroid drugs. Yes, they are the causes because they can cross the placenta. And can inhibit thyroid hormone synthesis in the baby. Okay. Maternal blocking TSH antibodies. Yes, they can also pass the placenta. And inhibit thyroid receptors in the baby. Okay. Iodine deficiency, yes, iodine deficiency can also cause transient congenital hypothyroidism. Rather even iodine excess can also cause congenital hypothyroidism. Thyroid dysgenesis, no. Thyroid dysgenesis causes permanent congenital hypothyroidism. Rather, thyroid dysgenesis is the most common cause of permanent congenital hypothyroidism. Okay. So the answer should be A, B and C. Option C should be correct. Okay. Moving on to the next question. Most common cause of permanent congenital hypothyroidism as discussed, it will be thyroid dysgenesis. Around 80 to 85% of the cases are due to thyroid dysgenesis. The second most common cause is dysharmonogenesis, which accounts for around 10% of the cases. TSH deficiency accounts for less than 5% of the cases, and thyroid hormone resistance is an extremely rare cause. So over here answer should be thyroid dysgenesis. Okay. Moving on to the next question. Match the following. Now this is regarding the classification of congenital hypothyroidism into primary, secondary and tertiary causes. Right. So before we move on to this, before we learn about the classification, we need to know the hypothalamic pituitary thyroid axis. So TRH is secreted from the hypothalamus. Which stimulates the pituitary to secrete TSH, and this TSH stimulates the thyroid to release T3 and T4, particularly T4. And this T4 in the peripheral tissues, gets converted into T3 via deiodinase enzyme. This is what happens. Now, when the thyroid gland is at fault, right, there is decreased production of the thyroid hormone that would lead to primary hypothyroidism. When the pituitary is at fault, this would lead to decreased TSH and that would lead to secondary hypothyroidism. And when the hypothalamus is at fault, then there would be decreased TRH and that would cause tertiary hypothyroidism. Right. So let's have a look. First, thyroid dysgenesis. Thyroid dysgenesis is a problem in the thyroid. There will be decrease in T3 and T4 secretion, right? So that would cause primary congenital hypothyroidism. Yes. TRH deficiency would cause tertiary congenital hypothyroidism. Pituitary malformation secondary, and deiodinase defect will inhibit the peripheral conversion of T3 to T4. So that would lead to peripheral congenital hypothyroidism. So the answer should be 1C, 2B, 3D, 4A. 1C, 2B. There is only one option with 1C. Answer should be D. Okay. Moving on to the next question. A 2-week-old baby with goitrous congenital hypothyroidism has elevated TSH and low T4. Which enzyme defect is most likely? There is increase in TSH and decrease in T4. Right. This is enough to diagnose it as primary congenital hypothyroidism. Why in primary congenital hypothyroidism? There would be decreased T3 and T4 synthesis, right, because of your involvement of the thyroid. And as a result of the decreased T3 and T4, there will be inhibition of the negative feedback on TSH. As a result, pituitary will produce more TSH, right? That's why TSH is elevated. So the most common cause, we all know that the most common cause of primary congenital hypothyroidism is dysgenesis, right? But over here the enzyme defect has been asked. So over here the problem isn't, the problem is dyshormonogenesis. Over here the problem is dyshormonogenesis, right? And in dyshormonogenesis, remember that the most common enzyme that is involved is thyroid peroxidase. This has to be our answer. Okay. 5' deiodinase helps in peripheral conversion, right? So it will lead to peripheral congenital hypothyroidism, as we discussed in our previous question. Pendrin defect. Pendrin is responsible for transport of iodine within the thyroid gland, right? So pendrin defect causes Pendred syndrome. Yes, this might cause this, rather this causes congenital hypothyroidism, but it is not the most common cause, right? And Pendred syndrome is also associated with sensorineural hearing loss. Okay. Thyroglobulin synthesis is also caused. This can also cause primary congenital hypothyroidism, but it is not the most common cause. So our answer over here would be thyroid peroxidase deficiency. Okay. Moving on to the next question. In most newborn screening programs, the initial test for congenital hypothyroidism is dried blood spot TSH. Remember the fact that for screening of congenital hypothyroidism, we check TSH in a dried blood sample. Via heel prick method, right? Taking the blood in a Guthrie card, taking the blood in a filter paper, which is known as the Guthrie card, and it has to be done on day 3 to day 5 of birth, right? It is never done on day 1 or day 2. Not done on day 1 on day 2, because on day 1 on day 2 there is a physiological TSH surge. There is a physiological TSH surge in the baby. This would result in false positive values. That's why on day 1 and day 2 we do not conduct this screening test, right? And if we talk about the values of TSH, if the value is less than 20 micro international unit per ml, we consider it as normal. Okay. If the value is between 20 to 40, we call it borderline. And if the value is more than 40, it is suggestive of congenital hypothyroidism. Okay. Then we perform the confirmatory test, which is this. Serum free T4 plus TSH together is the confirmatory test. The initial screening test is dried blood spot TSH, but the confirmatory test is both T4 plus free T4 plus TSH. Okay. So moving on to the next question. A 4-day-old newborn screening report, TSH is 45 and the total T4 is 5. TSH 45 means this is directly suggestive of congenital hypothyroidism, right? And a total T4 of 5. The normal T4 value is 10 to 15 micrograms or deciliter. So it is low. T4 is low, TSH is high, so it is primary congenital hypothyroidism. What is the appropriate next step? The next step in such conditions depend on the TSH value. Right? If our TSH value is less than 20, then that is normal, so we need not perform anything, right? No action is required. If the value is 20 to 40, this is borderline. In borderline, what do? We repeat test after 1 to 2 weeks. But if it is more than 40, we start treatment without delay. Right? Without delay means we need not confirm the diagnosis, we would start levothyroxine. Repeat the test after 2 weeks? No. Had the value been less than 40 and more than 20, then we would have repeated it after 2 weeks. Start levothyroxine immediately? Yes, we need to start levothyroxine immediately at the rate of 10 to 15 micrograms per kg per day, oral dose. Okay. Wait for confirmatory test? No, we would not wait. And ignore as false positive is also a false statement. Our answer should be to start treatment as soon as possible without any delay, even if we are not confirming it, if the value is more than 40. Okay. Moving on to the next question. Which statement regarding timing of screening is correct? Ideal time is within 24 hours of birth? No. It should not be done at 24 hours because of false positive results. We would get false positive results because of the physiological TSH surge in a newborn. Should be done between 2 to 5 days after birth? Yes, this is the true statement. Should be delayed until 2 weeks? No. Can be done at any time to 2 months? No. It should be done from day 3 to day 5. Okay. Excuse me. Now moving on to the next question. This is the test being shown in the image screens for. The test is the heel prick. This is the heel prick test. And this is our Guthrie card. This is our Guthrie card where the sample is taken. Okay, now this is used for phenylketonuria, yes, congenital hypothyroidism, cystic fibrosis. So all of this should be our answer, right? Now besides these, this is also used for galactosemia. This is also used for galactosemia, for congenital adrenal hypoplasia, for sickle cell disease, for G6PD deficiency, for others inborn errors of metabolism. For a lot of things this can be used. Usually for this inborn errors of metabolism. Okay. Usually when enzyme deficiencies are suspected. Moving on to the next question. In neonatal screening, a TSH value of dash on filter paper warrants further evaluation. Further evaluation means we have a borderline level. We have a borderline level where we need to repeat the test. It should be, the range should be 20 to 40. So the value should be more than 20 micro international units per ml. So the answer should be C. Okay. So moving on to the next question. Right. A 3-month-old infant presents with constipation, large tongue, puffy face, prolonged jaundice, umbilical hernia. What is the most likely diagnosis? Everything over here is suggestive of congenital hypothyroidism. Our answer is congenital hypothyroidism. Remember that in congenital hypothyroidism we get constipation because of decreased gut motility. Right? Hypothyroidism leads to decreased gut motility. This large tongue and puffy face is due to accumulation of mucopolysaccharides. Is due to accumulation of the mucopolysaccharides, right? Then gives us a mixed edematous facies. Okay. Prolonged jaundice is due to decreased or rather delayed biliary conjugation, again a feature of hypothyroidism. And umbilical hernia is due to decreased muscle tone. Okay. Which is the most likely diagnosis? Rated as congenital hypothyroidism. Everything is suggestive of congenital hypothyroidism. Now, besides these, if we talk about the other clinical features, the baby will have lethargy. The baby will have poor feeding. Right? The baby will have large fontanelles. The baby will have hypothermia. And delayed developmental milestones. Okay. It should not be cretinism. Cretinism is associated with severe growth retardation and mental retardation. Right. It is not Down syndrome. Down syndrome has other characteristic features and is not associated with constipation. There is no constipation. Is not associated with constipation. Congenital adrenal hypoplasia, no. Okay, these set of features are not seen in congenital adrenal hypoplasia. We would get ambiguous genitalia. We would get ambiguous genitals. You would get salt wasting. We might get hypertension and other features. Right. Moving on to the next question. Which of the following features suggest of congenital hypothyroidism in an infant? Lethargy and poor cry? Yes, we get lethargy and poor cry. Just a second. I'm extremely sorry for the cut. Right, we shall be beginning our discussion again from over here. Which of the following features suggest congenital hypothyroidism in an infant? Right. Lethargy and poor cry, yes, we do get lethargy and poor cry. Hypothermia, yes, we do get hypothermia. Excess sweating, no, we do not get excess sweating. Excess sweating is a feature of hyperthyroidism. And large fontanelles, yes, large fontanelles is also a feature of congenital hypothyroidism. So the answer should be A, B and D. C should be a correct answer. Moving on to the next question. You have untreated congenital hypothyroidism can lead to. So we need to discuss the complications over here. Irreversible mental retardation, yes. Growth retardation, yes. Delayed bone growth, yes, we get delayed bone age. Precocious puberty, no, we get delayed puberty. In hypothyroidism. So the answer should be A, B and C. Okay. Moving on to the next question. Identify the condition. Right, over here in this image we can see we get coarse features. The overall facies is extremely coarse. We get a coarse facies. Besides that, we get a puffy face, right? Array, we get a puffy face, and then we have this large protruding tongue. We get a large protruding tongue. Besides that, we have this nasal bridge, right? We get a wide nasal bridge. Right? And we also have umbilical hernia, right? Everything over here is suggestive of congenital hypothyroidism. Okay, so answer should be A, congenital hypothyroidism. Okay. Hurler syndrome has corneal clouding, although not evident over here, and moreover, Hurler syndrome is not evident from birth, right? It develops later in life. Beckwith-Wiedemann, we would have hemihypertrophy, which is not present over here, and in Down syndrome, we would have other features like the Mongolian slant. The Mongolian slant would be present. We would have got epicanthal folds. In the child, right? So moving on to the next question. Which of the following is seen in primary congenital hypothyroidism? In primary congenital hypothyroidism, your thyroid glands are at fault, right? As a result of which there will be decrease in T3 and T4. And this decrease in T3 and T4 would result in inhibition of the negative feedback on pituitary, as a result of which pituitary would result in excess production of TSH. So we would have decrease in T3, decrease in T4, and increase in TSH. So decrease T3, decrease T4, increase TSH. Option B should be our answer. Similarly, in secondary congenital hypothyroidism, we would get decreased TSH, which would result in decrease in T3 and T4. Whereas in tertiary, we would have decreased TRH, which would result in a normal to decreased TSH, which would result in decreased T3 and T4. Okay. Moving on to the next question. A newborn with midline defects and hypoglycemia with low T4 and low TSH, what is the diagnosis? We have low TSH and we have low T4, and the features are suggestive of congenital hypothyroidism, so it should be secondary congenital hypothyroidism, because in primary there has to be increase in TSH, right? In peripheral thyroid resistance, there will be increase in T3 and T4. There will be increase in T3 and T4. Whereas in TBG deficiency and thyroid binding globulin deficiency, there will be decrease in total T4. And normal TSH. Okay. Moving on to the next question. Transient congenital hypothyroidism. This transient congenital hypothyroidism is a congenital hypothyroidism which resolves, right? There is congenital hypothyroidism at birth, but it resolves on its own. Okay. So elevated TSH initially, yes, there would be a temporary decrease in T3 and T4 levels, so there would be increase in TSH initially. Normal thyroid gland on scan, yes, the thyroid gland should be structurally normal. History of maternal intake, yes, this is a very important risk factor. Besides that, we have iodine imbalance as a risk factor. We have prematurity as a risk factor. A normal T4 after 2 to 3 weeks without therapy, yes, right. Once the antithyroid drug is eliminated from the baby, or the baby acquires maturity, then the T4 is gonna normalize. So all of them are correct over here. Answer should be D, A, B, C, and D. Okay. Moving on to the next question. In thyroid scintigraphy, an absent uptake pattern means that the thyroid is not present over here, right? So either the thyroid is absent or is ectopically located. So our answer should be B. Because in other options, in dyshormonogenesis, your thyroid gland is present. So you would get a normal to increased uptake, right? Thyroglobulin defect, again your thyroid gland is present, you would get a normal uptake, right? In iodine deficiency, again your thyroid gland is present, but due to iodine deficiency, there will be increase in TSH. So there would be an increased uptake. Because of the increased TSH surge in that patient. Okay. But absent uptake will be seen in thyroid agenesis or ectopic. Okay. Moving on to the next question. The initial treatment for congenital hypothyroidism, as already mentioned, it is levothyroxine at a dose of 10 to 15 micrograms per day orally, right? It has to be T4. We do not supply leothyronine, which is T3. We do not supply that because it has a short half-life. Short half-life means it is very difficult to monitor. And remember that monitoring plays a very important role in management of congenital hypothyroidism. And moreover, it is considered too potent for the baby, right? Levothyroxine at a dose of 50 microgram twice a week is low dose, and desiccated thyroid extract is also not used anymore, right? So the answer should be levothyroxine at a dose of 10 to 15 micrograms per kg per day orally. Moving on to the next question. A 2-week-old infant started on levothyroxine for congenital hypothyroidism. Which of the following should be monitored initially? So if we talk about monitoring, the monitoring is done by testing both TSH and T4. How is it done? Start at the rate of 2 weeks, every 2 weeks, every 2 weeks, I'm sorry, not at the rate, every 2 weeks until normalization, till it gets normalized. What I mean by normalization, that T4 is more than 10 and TSH is less than 10, right? TSH ideally TSH should be less than 5. Okay. So after 2 weeks, after the things get normalized, after your T4 values get normalized, we would monitor at the rate every 1 to 3 months, till 1 year, then every 2 to 3 months, till 3 years, and then 6 monthly. Okay. So this is the monitoring. So over here, what should be monitored initially? Free T4 and TSH every 2 weeks until normalization. Yes, this is our answer. T3 is not monitored because it is unreliable, right? Thyroglobulin titer is actually used for dyshormonogenesis. Serum calcium is for PTH issues, not in thyroid issues. Okay. Moving on to the next question. After initiating therapy, monitoring should include serum T4 and TSH every 2 to 4 weeks till normalization. Yes, ideally 2 weeks. Okay. Growth and neurodevelopmental assay assessment. Yes. Repeat bone age every 6 months. No, bone age is actually not a part of regular monitoring. Okay. And repeat TSH and T4 every 1 to 3 months in first year. Yes. So A, B and D should be our correct answer. So C should be correct. Okay. Moving on to the next question. Regarding the treatment of congenital hypothyroidism, which of the following are true? Delay in treatment by more than 2 weeks increases the risk of irreversible mental retardation. That's a true statement. Delay by any amount of time is bad for the child, and a time of more than 2 weeks increases the risk of irreversible damage. Okay. Tablet should be crushed and mixed with, yes, this should be followed. A tablet should be crushed and mixed with expressed breast milk and given to the child. Liquid formulations are not preferred, right? Always a tablet is preferred. Avoid giving with soy-based. Yes, this is a true statement, right? Soy-based and calcium supplements. We need to avoid soy-based formula and calcium supplements in a child who has been given a levothyroxine supplement because they decrease thyroid absorption. Okay. So answer should be A, B and D. Yes, A, B and D. Option C should be correct. Okay. Moving on to the next question. A neonate is diagnosed with congenital hypothyroidism and is started on levothyroxine at the rate of 10 microgram per kg per day. After 2 weeks, T4 is normalized, but the TSH remains high. What should be done? See, when you are providing levothyroxine supplement to a child with congenital hypothyroidism and you see a normal T4, this suggests that replacement is provided. Had the replacement been not provided, your T4 wouldn't have normalized. But high TSH suggests that the replacement that has been provided is inadequate. So what should we do? We should just increase the dose. Continue the same dose? No, we should not continue the same dose because again this is not enough to bring the things to normal, right? Increase the dose. Yes, we should increase the dose. Add T3? No, T3 is again too potent and has a short half-life. Stop the treatment? No, this would rather worsen. This would worsen the condition, right? Normally a T4 should be more than 10 and TSH should be less than 10, right? Ideally TSH should be less than 5. Okay. Moving on to the next question. Trial of therapy must be considered. What is trial of therapy? Trial of therapy is temporary stoppage of T4 supplementation, right? Temporary supplementation and is done at 3 years. Answer should be C. This is to rule out transient congenital hypothyroidism. Now after 3 years, we stop levothyroxine for 4 to 6 weeks, and then we check TSH and T4 levels. If the things are normal, then that is transient congenital hypothyroidism and we can stop the drug forever. But if the your T4 is low and your TSH increases, then it is permanent. It is permanent. I'm sorry. Permanent congenital hypothyroidism. Right? We have to continue the drugs again. Moving on to the, so our answer should be 3 years, right? It should be done at 3 years, not before that. Moving on to the next question. A child diagnosed with congenital hypothyroidism on newborn screening has normal thyroid function after stopping levothyroxine at 3 years. What is the diagnosis? As just discussed, if we get normal thyroid function, it has to be transient congenital hypothyroidism. Okay. Moving on to the next question. A 2-year-old on levothyroxine for congenital hypothyroidism is not gaining weight despite good T4 levels. What is the most probable diagnosis, right? Over here, in a child with congenital hypothyroidism, we are providing levothyroxine, but the levothyroxine has brought the T4 levels to normal, but is not causing a gain in height. The most probable cause in such condition is an associated endocrine anomaly. Associated endocrine anomaly, which is most commonly in the form of growth hormone deficiency, right? It is most commonly in the form of growth hormone deficiency. Okay, so if we have a look at the options, improper timing of the drug won't cause this feature of loss in failure to gain height, right? Non-compliance, had there been non-compliance, your T4 level wouldn't have improved, right? So there is no non-compliance, there is coexistent growth hormone deficiency. And overdose again would have resulted in an accelerated growth, not a failure of growth, failure of gaining height, right? So the answer should be coexistent growth hormone deficiency, which is quite common with congenital hypothyroidism. With this, we come to the end of our discussion. If you like this video, consider subscribing to my channel, and thank you for watching.